Hey, everybody. Welcome back to Pulm Peeps. We are excited to be back again today with another episode and joined by our two amazing associate fellow editors, Rupali Sood and Tom DiViantonio. And very excited to be back with another episode on a topic that is near and dear to my heart. So really looking forward to this. Monty, how are you?
Hey, Furf, I'm doing well. Very excited to be back with this crew. And I know I was actually pulling up our infographic for the asthma guideline series that Rupali and Tom made and was referencing it the other day. I continue to use this, so hopefully those listening today will find these series very helpful and relevant to your day-to-day practice.
Yeah, absolutely. And today we're going to be going forward with our guideline series. We're going to be moving on to a new topic, which is pulmonary hypertension, my favorite topic. Pulmonary hypertension is super interesting and fascinating field, spans pulmonary and cardiology, depending where you are, but very important for all pulmonologists to be extremely familiar with the guidelines. And interestingly, there are multiple organizations that play a role in how we think about pulmonary hypertension. And so whoever has the most recent guidelines usually becomes what we're functioning on. So for a long time, the World Symposium on Pulmonary Hypertension had the most recent guidelines, what we were following. But more recently, in 2022, the European Society of Cardiology and the European Respiratory Society released updated guidelines that had some changes and have influenced how we think about and practice our pulmonary hypertension diagnosis and treatment. So we are going to start today diving into those guidelines with a foundational episode. We're going to talk about symptoms, screening, and diagnostics. Some of these things will be similar to the old guidelines, but we're going to review all of it. And then we'll try to make a good point of highlighting what has changed and what has developed and how we should rethink about some of these topics.
Awesome, Furf. And I know you love pulmonary hypertension. I think that more than anyone I know, it's just so exciting and such a great topic to cover. I think for a lot of trainees and for fellows and even some attendings, pulmonary hypertension can be a very scary topic. But our hope today is to walk through it, give everyone a great foundation. Obviously, we can't cover everything in PH in one episode, but give you a good framework to start thinking about your patients where you suspect it. Our roadmap today of what we're going to cover, we're going to try to cover 7 broad topics within PH to give you this great framework. The first one is going to be when to suspect pulmonary hypertension. Right? This is going to be recognizing clues and risk factors in patients that you're caring for. The second part of our roadmap today is going to be the World Health Organization classifications. So understanding the 5 groups of PH and some of the baseline pathophysiology associated with each group. Our third part on the roadmap is going to be interpreting echocardiography. And I know we'll go through how to assess the probability of PH based on echo findings. Our fourth stop is going to be non-invasive testing. So which tests to order, when to order them, and what they're going to be telling you. The fifth stop is going to be right heart catheterization, and we'll go through a little bit in this, and I'm sure we'll interpret some numbers and give you some values to keep mind of. And this is going to be when is a right heart cath indicated, how it's performed, and how to interpret the results. The sixth part will be vasoreactivity testing. Again, this is going to can be part of a right heart cath diagnostic test. We'll talk about who qualifies, how it's done, and what a positive result means. And then the last stop of the roadmap today is going to be screening high-risk populations. So this can be how to approach patients with conditions such as connective tissue disease, HIV, or portal hypertension that you should be aware of. So excited to go through all of this together with this crew.
Yeah, thanks, Monty, for the roadmap. And I think that looking forward, we will, after talking about these conditions, talk some more specifically about other diagnostics. We'll talk about specific conditions, and then we'll really dive into treatment broken down by the most common conditions and how to think about that. So a lot of great episodes coming in our future. As I already said, we're thrilled to be back with Rupali and Tom. Rupali, you were just jet setting for multiple weeks. I'm glad that you landed safely and are back on Pulm Peeps today.
Thanks, Dave. Happy to be back. I lost my voice a little bit, but excited to be here with this crew and I'm ready to get this started. And this episode is such a great starting point for pulmonary hypertension. Pulmonary hypertension can be a very subtle diagnosis at times, and recognizing it early can really change outcomes for patients. So I'm really excited for this specific episode today.
Awesome. And Tom, it's always great to have you joining us as well, even if you've only been just stuck in Baltimore for the past couple of weeks.
Yeah, I've been mostly hanging out in Baltimore recently. I have not been traveling around like Rupali has, but
Excited to be back with everyone. And from a fellow standpoint, I think having a clear diagnostic framework for how to approach these patients is a really helpful thing to have in your back pocket when you're seeing someone in clinic or in the hospital with unexplained dyspnea. Yeah, absolutely. So just our standard disclosure, this episode is not meant for specific medical advice, but for medical education, and the opinions and that we reflect, or the opinions that we share, may not reflect those of our respective employers.
Great. So fantastic to get started. And to help ground this discussion, I know we always think it's really important to provide any teaching and pair that with a actual patient case, because we always have to bring it back to the patient and bring it back to the bedside. But Rupali, hoping you can start us off.
Definitely. I'll tell you about a patient I saw in clinic. This was a 58-year-old woman with limited systemic sclerosis that she'd had for years, who presented to clinic and was referred for progressive dyspnea over the past 10 months. She used to be able to walk several blocks without any problems at all, but now she gets short of breath when she just does basic tasks around the house, including getting up to just cook in our kitchen and putting her clothes on in the morning. She had no obvious parenchymal disease on CT, including any evidence of ILD or any obstructive lung disease. She had no symptoms of chest pain, no orthopnea, no P&D, but just some vague, slow developing shortness of breath. This is a classic setup where pulmonary hypertension might fly under the radar. So let's try and keep her case in mind as we go through the framework today.
Thanks, Rupali. That's a great example to kick us off with. She, as we'll talk about, is one of those patients who has a risk factor for developing pulmonary hypertension in her systemic sclerosis. And that slow, insidious, unexplained decline is often how it presents.
Yeah, thanks so much, Tom. And thanks, Rupali, for getting us started with that case. And I think you write a very common presentation that fellows may be seeing in their continuity clinic or residents taking care of a patient. This may be someone who's coming in their clinic as well or being admitted. So very common presentation. And you mentioned some great things already to probably help us thinking, as we said, this progressive decline over the last 8 to 10 months, dyspnea now on exertion, fairly normal parenchyma on CT images, but I know there's so much more that we would want to delve into, getting a little bit more history as well as exam and some further diagnostics. But Rupali, just thinking about pulmonary hypertension in general, when should we actually suspect it?
That's a great question, Monty. And as we mentioned, the most common presenting symptom is often just dyspnea, and especially dyspnea on exertion specifically. But it is a little bit non-specific that often pulmonary hypertension is not considered until later. Other associated symptoms can include fatigue, lightheadedness, exertional chest pain, or syncope, particularly as right heart dysfunction develops. These symptoms, specifically the insidious onset of dyspnea on exertion, had me thinking about my patient. As you mentioned, physical exam is an important part of what we do. In later stages of the disease, you can also start to see other signs of right heart failure, like peripheral edema, elevated JVSP, specifically thinking about evidence of tricuspid regurgitation on exam. You can look for exaggerated V waves on exam, hepatomegaly, and ascites. My patient did have some lower extremity edema as well as some V waves on exam of her neck, which had me thinking about this particular condition.
Those are all great things and things that I'm thinking about when I'm suspecting PH. And we'll talk a little bit more about the other conditions that really raise red flags. A big red flag for me, and a lot of times when people end up in my clinic, is that the symptoms that they're having are just not aligning with our classic objective data in our pulmonary clinic. So they might have a relatively normal CAT scan, or at least the parenchyma appears relatively normal, but they're having this severe dyspnea on exertion. They also might have normal spirometry, because we often don't see the defects of pulmonary hypertension on just a basic spirometry, FEV1, FVC, but their dyspnea is getting worse. And we'll talk about some of the other features that we can look for to give us a hint about pulmonary hypertension. So these disconnects always put PH on my radar, or at least someone I want to think about pulmonary vascular disease. And I'll just add the importance to this. So one is that we know there is a persistent delay in diagnosis for pulmonary hypertension. So this has gone down over time, but still, depending on the sources you look at, is somewhere between 12 to 24 months from the time that symptoms onset and the patient's really experiencing it, and we get this diagnosis of pulmonary vascular disease. And then there's often a delay after that between the diagnosis and treatment. And this is profound impact for our patients. Any delay that they have can increase their mortality, because this is a pretty morbid condition overall. Depending on where you look, someone might say that a delay of 2 years would increase your mortality by about 10% over the next 5 years. A delay of 5 years, increased mortality by 25%. These are real numbers that we care about. And so some of the changes in the guidelines and some of emphasizing this high clinical suspicion have really been focused on trying to make these diagnoses earlier, and especially in patients with pulmonary arterial hypertension. So we'll talk about the different subtypes, but this is the group that can often go missed. It might be a little bit younger patients. They might not have classic other findings. And if we can make this diagnosis early, we can really improve their disease course over time. But if we delay this diagnosis, it can have profound impacts for them.
Yeah, they're so important to think about. And thank you for mentioning that. And I think another important thing to think about when we think about pulmonary hypertension as a possible diagnosis, there are really two important portions of the diagnostic workup. And the first is really confirming the diagnosis. And I know we're going to go through all of this, but I think a teaching point for those listening today, right? I know sometimes people will put in a one-liner or put like in an assessment and plan, a patient has pulmonary hypertension, but they're writing that based off of the patient but potentially having an enlarged pulmonary artery on CT finding, which is not a diagnostic test, and or suspecting on echo that the patient may have pulmonary hypertension. And we're going to walk through all of this together. But really what you need to confirm the diagnosis is actually a right heart cath, which we'll also talk a little bit later today. But I think that's really important. When you're saying someone has pulmonary hypertension, you're going to want the evidence behind it with that right heart cath and the diagnostic and the numbers. I think all four of us had the opportunity to work with Paul Hassoun. And I remember as a fellow talking about a patient with pulmonary hypertension, he's like, yes, but tell me why. What's the mean arterial pressure? What are the Woods units? And he's in Christina, what is a cardiac index? So all of these things are going to be needed that we can't get alone from just looking at imaging and looking at echo. So the first, how do we walk through confirming the diagnosis? And the second is to really think about why the patient may have pulmonary hypertension. And I think we'll have to focus a bit on the etiologies and to help us think about why a patient may have this and really determining pretest probability of PH. So Tom, I know one of the stops of the roadmap, I said we're going to talk about the 5 etiologies that are classified by the World Health Organization, and I'm hoping that you can walk us through those now.
Sure, I would love to. As Christina was saying, we tend to group pulmonary hypertension into 5 buckets, group 1 through 5. I feel like this is where a lot of us get exposed to this in medical school, and the prototypical patient we learn about in medical school is the person that falls into group 1. That's the young woman with exertional dyspnea who has pulmonary hypertension, but there's a whole lot more conditions that can lead to pulmonary hypertension and a lot of different phenotypes and pathophysiologies. So when you get to group 1 pulmonary hypertension, this is where we're thinking about PAH, pulmonary arterial hypertension. And there's a lot of things that can cause this. Your classic teaching is idiopathic, IPAH. But there's also many heritable forms of PAH. And as our testing abilities and understanding of molecular diagnostics gets better, we're uncovering more and more mutations that can predispose someone to PAH. This is also where you'll find folks with drug-induced pulmonary hypertension, things like dasatinib, connective tissue disease-associated PAH, such as scleroderma, systemic sclerosis, portopulmonary hypertension, HIV, HHT, hereditary hemorrhagic telangiectasia. This is also where you put patients who have PAH secondary to congenital heart disease or shunts. It lead to increased flow through the pulmonary circulation and pulmonary hypertension. And then lastly, you get some much more rare, but really important things to consider, such as PVOD and pulmonary capillary hemangiomatosis, PCH. Now, moving on to group 2, which is where you actually find most causes of pulmonary hypertension. These are pulmonary hypertension cases related to left-sided heart disease. So folks with left-sided heart failure, particularly things like HFpEF, are really important. Group 3, this is where you find pulmonary hypertension related to chronic lung diseases, hypoxia, things like COPD, interstitial lung diseases, and then obesity hypoventilation syndromes in particular. Group 4, these are patients with chronic thromboembolic pulmonary hypertension, also called CTEPH. And then lastly, group 5, these are conditions that lead to pulmonary hypertension through a multifactorial pathophysiology or some unclear mechanism. This is where you find conditions such as sarcoidosis, myeloproliferative disorders, chronic kidney disease, and sickle cell disease. This classification is really helpful in thinking about how you're going to proceed with your workup. In our patient, for example, their systemic sclerosis raises concern for group 1 PAH or group 3 PH if they were to have some ILD, which many patients do, but we need data to confirm.
And Tom, I'm just going to hop in and add for this. One of the reasons that these categories are so important is, or the way the categories are made, is one is based on histopathologic diagnosis, like what changes do they have in the pulmonary vascular system? And that can get a little murky. People with group 2 and group 3 disease can start developing some of the changes that we see in patients with group 1, intimal hyperplasia, plexiform lesions, things that we see on histopathology. But they also can have pulmonary hypertension without those, driven by their other disease. So this is where we get like a lot of overlap between them. But in addition to the histopathologic, a lot of this has to do with treatment. How quickly do we have to treat, and what treatments are going to be most beneficial? And so these categorizations really help us in both that prognostication, diagnostics, prognostication, and then ultimately in treatment, which we'll talk about in further episodes.
Thanks, Tom and Dave. That's such a great framework and a way for us to think about ILD. As you mentioned, as soon as I started thinking about my patient and ILD, I knew she had systemic sclerosis, so I was thinking about group 1 versus group 3 pulmonary hypertension as a possibility. And like David mentioned, sometimes it's difficult to parse out how to group these patients because sometimes their conditions can help them fall into various categories, so they can fall into multiple categories. And it's important for us to think about treatment as aligns with that. For example, systemic sclerosis can be group 1, group 3, and we know something like sickle cell disease can really span all of the groups, and that can be difficult sometimes. But once we are suspicious for pulmonary hypertension, we really want to further clarify our pre-test probability of this disease. So this includes some of the things that we have discussed, including a physical exam where we look for signs of RV failure or RV strain. We talked about peripheral edema, elevated JVP, evidence of tricuspid regurgitation with exaggerated P waves, pulsatile liver, pronounced P2, and RV heave. However, sometimes these can be absent in early disease, and so it's also important to think about other tests we might want when this patient is presenting to us in the clinical setting. So other things that we can look for that could clue us into this etiology may be other findings on physical exams. As Tom mentioned, there are a lot of systemic conditions that can often be associated with pulmonary hypertension. For example, if the patient has telangiectasias, we can maybe think about one of the connective tissue diseases, scleroderma, the HST mentioned. And if they have clubbing, we may worry about group 3 related sort of hypoxemia and other diseases. But beyond the physical exam, there are some initial tests that the guidelines recommend that we should be ordering for our patients when we have a high pre-test probability of pulmonary hypertension. So the first is natriuretic peptide, or NT-proBNP. And this is specifically to look for evidence of RV strains. Just as the left ventricle gets strained, the right ventricle can be strained and stretched in the same way. And ordering this test, and if it's elevated, can be from baseline, can be helpful in helping to increase the pre-test probability of this disease and make us more sure on our diagnosis. The second thing that we should do with our patients in clinic is arresting oxygen saturation. But more importantly, as I mentioned, it's important to pair this with ambulatory saturations, as pulmonary hypertension is much more evident on exertion because exercise increases the demand on the cardiopulmonary system, and it usually will unmask that abnormal pulmonary vasculature response that could be hidden at rest. So very important to get ambulatory sats and to even consider a 6-minute walk test, because that really helps to provide a baseline as to functional capacity for our patients, which is important because a lot of our treatment parameters actually focus around that as well. And the last thing I'll mention that can be easily done, especially in the inpatient outsitting setting, is a chest X-ray and EKG. These are lower yield generally, but sometimes you can see signs of RV enlargement, right axis deviation. And then most importantly, number one most important screening test to order when we have a high pretest probability of pulmonary hypertension is a transechogram, because we get a lot of rich information. And I'm hoping, Dave, you can focus us in on the transthoracic echogram, or the TTE, a little bit more.
Yeah, absolutely. Before I dive into echocardiogram, which is certainly one of my favorite topics, I just can't stress enough how much NT-proBNP is valuable in our clinic, pulmonary hypertension clinic. One, I'll say NT-proBNP is better than BNP if you can get it. It has a little bit better sensitivity in mild to moderate heart failure. But for our patients with RV remodeling and RV strain, and then sometimes fluid overload, NT-proBNP is just an enormously helpful biomarker. We even trust it. I feel like I won't say more than in left heart disease because they also use it a lot, but I feel like a lot of times we're qualifying NT-proBNP as the patient's obese, maybe it's lower. For our patients, we are aiming to have this normalize over time, and it has enormous prognostic value, and it's helpful in somewhat in the diagnosis as well. Someone has a normal one, I'm much more reassured about their RV remodeling. So just a really helpful test. But let's go back and focus on the echocardiogram for a moment. This is the number one way that patients get referred to a pulmonary hypertension clinic or get pulmonary hypertension shoved into their one-liner, is that they have an echocardiogram, it's a good screening test, and we see evidence of pulmonary hypertension. But what does that mean? When people are looking at evidence of pulmonary hypertension on echocardiogram, what are they looking at? And these guidelines, the ERS guidelines, have one of the best figures that I've ever seen in this in looking at how we should think about reading echocardiogram and the echocardiographic features of RV dysfunction or pulmonary hypertension. And we'll share those images along with this episode. So the guidelines define pH probability on echo with the first step looking at the peak tricuspid regurgitant velocity, and then looking at the presence of other signs of pulmonary hypertension. So when we're looking at the peak tricuspid regurgitant velocity, the first thing to know is that the presence and severity of TR, while linked to the peak velocity, is not synonymous. So just because a patient has severe TR or moderate TR doesn't mean they have a high peak tricuspid regurgitant velocity. They often go hand in hand, but a patient could have a primary valvular disease and not have pulmonary hypertension, but have raging tricuspid regurgitation. You could also have a patient who they just can't really get a tricuspid jet. They don't see a lot of tricuspid regurgitation, and that can be a little bit reassuring, but it does not rule out pulmonary hypertension because what we're really using this peak speed as is an estimate of our pulmonary artery systolic pressure. So it's important to know that they're linked, but not synonymous. So when they're doing this, they're trying to get a good envelope of the tricuspid regurgitation and then use some of their echo assessment tools to look at peak tricuspid regurgitant. So when we think about the risk factors for pH and screening and deciding based on our echocardiogram who should go on to have a right heart cath, we think of this in really three categories. So the first is low probability. Someone whose tricuspid regurgitant velocity is less than 2.8 meters per second, who has no other signs of RV dysfunction, and who had a relatively low pretest probability for pH, we can be really reassured this is pretty low probability that they have pulmonary hypertension. For patients whose peak tricuspid regurgitant velocity is between 2.9 and 3.4 meters per second, we start to get a little bit more concerned. This is intermediate risk of pulmonary hypertension. So the things that will then move me from seeing this on a cath to seeing this on an echo to doing a right heart cath is one, how high was my pretest probability? Is this a scleroderma patient where I'm really concerned? Is there NT-proBNP 1500 where I'm really concerned that they might have this? If that's the case, just that 2.9 to 3.4 will be enough alone to move me towards a catheterization. Well, my pretest probability is low, but I see this value, and then I see some other suggestive signs on echocardiogram that they might have RV dysfunction or pulmonary hypertension. That will also move me down the algorithm to thinking about a right heart catheterization. And then finally, we have the high risk, someone whose peak tricuspid regurgitant velocity is 3.4 meters per second. For this, my antennae are up. I'm likely going to do further investigation if I think it's going to impact their treatment over time. I will also still look for additional signs of RV dysfunction or pulmonary hypertension, but this makes me a lot more concerned. So what does that velocity translate into? Because most of the time, people don't reference that. What they reference is an estimated pressure that they get. So it's important to know how your echo lab is doing this. So are they estimating RV systolic pressure or PA systolic pressure? And what are they using to calculate that? So the standard is that we're estimating our pulmonary artery systolic pressure, which is that TR velocity squared times 4. And so that is giving us a number that's either in that 29 to 70 range, depending on the severity, right? Getting us for a millimeters of mercury, trying to have an assessment of this. And then it's important to know if your echo lab is adding right atrial pressure to that or not. And so the echo labs might use different techniques to estimate right atrial pressure. It's usually based on IVC dilation and collapsibility. And they're usually very broad buckets. Like the IVC is less than 2 centimeters and collapsible. So RA pressure is 0 to 5. It's dilated but collapsible. So it's 5 to 10, or it's dilated and not collapsible. RA pressure is 10 to 15 or greater. And so when you're reading those reports, just helpful to know what they report. But the standard is they're saying estimated PASP, TR velocity squared times 4. And then it is also helpful to know what they categorize as mild, moderate, or severe elevation. And so this varies based on the literature that you look at. Generally, normal is less than a predicted PSP of 29 millimeters of mercury. And that corresponds with that 2.8 meters per second. So if we're less than that, we have a low probability of pulmonary hypertension. Mild might be 30 to 40, moderate 40 to 50, and severe 50 and above. Some people are a little bit less conservative. They might say moderate is 45 to 60 and severe is greater than 60. But the important thing is not what they say it is. It's not mild, moderate, severe. It is looking at that peak tricuspid regurgitative velocity, that estimated PASP, and then using that for this algorithm that these guidelines defined. So I referenced that once we have this TR velocity, we're in our low, intermediate, or high probability group. This is, of course, influenced by our pretest probability, by some of the conditions we already mentioned, and some of the other tests that you talked about, Rupali. But then we want to look at the echo and for other signs of pulmonary hypertension. And again, I think that the guidelines give us a really good image to summarize these. And so we'll share that. But in general, what we're looking for is RV enlargement or dysfunction. So this can either be a qualitative assessment. The echo reader says, hey, this RV is a little dilated, or the free wall has some mild or moderate dysfunction. And then we also have some metrics that can help us with this. The TAPSE metric, the metric was the tricuspid annular pulmonary systolic excursion. Basically, how much longitudinal movement does the RV have, measured by where the tricuspid valve annulus moves up and down as it squeezes, can help us with the function. The RVS prime, which is a similar metric, but looking at the speed of that movement, can be helpful. And then the RV basal diameter, which is giving us a metric of dilation. So what we really care about, and what I follow in the pulmonary hypertension clinic, is RV size and dysfunction. And so I'm trying to get metrics to measure both of those. Other signs that someone might have RV, right-sided overload or pulmonary hypertension, atrial enlargement, we usually looked at on a 4-chamber view. Septal flattening. So we go to the parasternal short and we try to see when the RV fills and squeezes, does it flatten and impinge into the LV? And we get based on when this occurs in the cardiac cycle, we get some different understanding of their RV. So if the septum is only flattening when the RV squeezes in systole, this is really pressure overload. We worry that the patient has pulmonary hypertension. The RV has had to become a little bit hypertrophied and dysfunctional. When it squeezes, it generates high pressures and impinges into the LV. If that septum is shifted also in diastole, we think of that more as a volume problem. So when the RV is getting filled, we have elevated RV filling pressures, and that's also squeezing into the LV. And so that might be volume pressure overload. So we look for those metrics. We look for a dilated pulmonary artery. And then we look for pericardial effusion, very bad sign in our patients because it may indicate that they have chronically elevated filling pressures. And so if we see one of those signs of RV dysfunction or pulmonary hypertension, there are some others as well, along with an intermediate risk estimation of their pulmonary artery pressure on echo, we get much more concerned. We're going to say we probably need further testing in this patient.
Thanks, Dave. That was extremely helpful. And again, just as you mentioned, a TT is a good initial screening test. It's not diagnostic of PH, but it is highly suggestive, and it really helps us refine our pretest probability for pulmonary hypertension based on all the parameters you mentioned. And I also like to think about it as a helpful tool to use to follow patients with pulmonary hypertension because, right, as you mentioned, it's a helpful first screening tool for us to get an assessment of where in that mild, intermediate, high probability category does our patient fall. But then if we do start treatments over time, we can follow some of these parameters. One other thing I wanted to mention is that the TTE specifically, we get all of these different parameters from it. And then we are looking for pulmonary hypertension based on that TR jet velocity, but also we're looking not just for that pulmonary hypertension piece, but for how the RV is functioning. So those things, I like to separate them a little bit because I also want to know how much the RV is compensated in a certain patient and how aggressive we may need to be as we start different treatments and how aggressive we need to be in treating that patient based on some of these screening parameters. So with that framework in mind, I just want to share what my patient's TTE revealed. Her TTE showed a TR velocity. They were able to get a good jet at 3.1 meters per second. She had some mild right atrial enlargement, which puts her, based on that reference image that Dave mentioned in the guidelines, in the intermediate probability group based on those guidelines. So other echo signs that she had on her TTE included a PASP, which again, as we mentioned, is a back calculated value using the jet velocity, as well as the RA size around 45. She had moderate RV enlargement, just qualitatively called on the echo. And then she had a TAPSE or tricuspid annular planar systolic excursion, as Dave had explained to us, at 1.6, which is below a cutoff of sort of 1.7 that we often think about in what patients, how their RV is functioning. And given her exam and some mild evidence of volume overload, I wanted to start addressing some of these initial issues that she was having, specifically thinking about, did she need some volume optimization with diuretics? But Dave, it looks like you might have something to add.
No, I just wanted to say thank you for correcting my acronym. You think you appropriately said tricuspid annulus plane or planar systolic excursion. I think I misspoke. It said pulmonary. I always have lungs on the mind. Just pointing that out for our listeners.
We all always have lungs on our minds, which is good in our field. But with my patient specifically, I told her that I think that you may have this condition we call pulmonary hypertension. I see some evidence that the right side of your heart may be struggling to keep up with some of the demands and that some of that fluid is backing up. And so let's start you on these drugs to try and get some of that fluid off and optimize the right side of your heart. But Monty, what other things should I be thinking about in terms of workup? And maybe just more broadly thinking maybe in this patient specific context, but for other patients that may or may not have the risk factors that she had, how should we be thinking about other tests and grouping those patients appropriately?
Thanks so much, Rupali. Yeah, right. So think about a patient who you have a high pretest probability for. In addition to pursuing the right heart cath, as we mentioned, you're going to want to understand the why. We need to pursue a targeted non-invasive testing in parallel, right? So thinking about potentially patients with connective tissue disease, you're going to want to send off serologies, ANA, rheumatoid factor, potentially ANCAs based off history and physical exam. Things that you should be having on your differential are going to include lupus, vasculitis, scleroderma, mixed connective tissue disease, and potentially rheumatoid arthritis. And other non-invasive diagnostics to consider are going to be pulmonary function test. Specifically, get a full set, so including spirometry, lung volumes, as well as DLCO, diffusing capacity. These are going to be helpful in almost every patient. Teaching Pearl, I know some of you may have heard about, if you do have an isolated low DLCO, but normal spirometry and normal lung volumes, that could be a window into underlying pulmonary vascular disease. Other imaging diagnostics are going to be a VQ scan. This is going to be best screening tests for CTEP. High-resolution CT chest. This is going to help us look for any underlying parenchymal disease, specifically if we have a high suspicion for interstitial lung disease. And then we can't forget about our overnight oximetry, especially if OSA or nocturnal hypoxemia is suspected. Right, so this is really our chance to figure out the likely WHO group. However, right heart cath is the gold standard, as we've talked about today, and we'll continue to talk about throughout this episode for confirming pulmonary hypertension. It'll help us determine if it's pre versus post capillary and really guide treatment. So when do we need to do that? If the echo shows intermediate or high probability of pulmonary hypertension, the non-invasive workup supports pulmonary hypertension, and if you're considering PAH-specific therapies. For any other thoughts that you have?
I think one question that comes up in PH clinic a lot, especially from fellows, is when are we ordering all of these other tests to look for etiology of pulmonary hypertension? And I think it depends. When I have a patient who I'm really not sure if they have it, or if I'm like really 90% sure that this is going to be chronic ILD or pulmonary hypertension from heart failure that's causing it, I'll wait on some of these tests and get the right heart cath and then decide what I need to screen for. But a patient like this, who I have a really high probability of pulmonary arterial hypertension, I really want to do the full workup right away. At some point, we're going to have to call this group 1 pH, which is likely is going to be if she does end up having it with scleroderma. And so I just want all these tests to make sure there's nothing else I'm missing, that they don't have a group 4 component, that they don't have some other component that I really going to need to optimize. So some of it depends on your pretest probability. But for this patient, I would plan on the right heart cath and then start gathering this battery of tests right away.
And then, Dave, I'll just add that in my patient's case, we did pursue a lot of the work that Monty mentioned. When we did her PFTs, her FVC was preserved, but her DLCO was only 42% predicted, which really started to raise my suspicion for group 1 PH in this patient and had me thinking specifically about pursuing a right heart catheterization. Tom, can you tell us a little bit more about the right heart catheterization?
Yeah, absolutely. So as we've alluded to throughout this episode, while echocardiogram, physical exam, history, all of these things are really critical pieces of our workup for pulmonary hypertension, the gold standard is a right heart catheterization, and we truly can't make the diagnosis of PH without that procedure. I'm sure most of our listeners are familiar, but a right heart catheterization is a procedure where a catheter is placed usually into the veins of the neck and floated through the chambers of the right heart, measuring pressures at different locations, including the right atrium, the right ventricle, the pulmonary vasculature. And we're getting those pressure and oxygen saturation readings at different locations. And this is critically important because the definition of pulmonary hypertension is based on this. I do want to note that, as we've also been discussing, it's important to think about your pretest probability for what type of pH the patient has, because that can inform what tests you may or may not do during the right heart catheterization. I'm sure it happens, but it would be unfortunate to have to do a right heart catheterization and then realize you need vasoreactivity testing and then have to go back and do it. So
Tom, that is a great point. Like, another great reason sometimes to do that workup first is that we're not just blindly throwing this catheter in, and there are different maneuvers and procedures you can do. So that's a really great point to have.
Yeah, absolutely. So turning back to the physiology, we've talked about how pulmonary hypertension is defined by elevated pressures that the right side of the heart is seeing. But this could either be due to increased resistance, so occurring in the pulmonary vasculature, at the level of the lungs, at the level of the pulmonary artery, or it might be high pressure and volume coming from the left side of the heart, leading to backflow, like a system of pipes backing up. Rupali, can you tell us a little bit about the different parameters that we look at and how that helps us?
Definitely, Tom. Thank you so much. And like you mentioned, I think a lot of us like to think about this as a plumbing system, which will be helpful as we go through some of the ways that we think about right heart catheterizations. And I'm going to go through some of the important numbers that you should be looking for in a right heart catheterization. And then I'll ask Dave to layer on some of the important numbers as well that we should be mindful of when we're interpreting these right heart caths. So one thing to note is that we have some values, as you mentioned, Tom, in a right heart cath that we measure directly. So those pressures that we're measuring in the right atrium, as we go through the system, our ventricle, right? And then we wedge the catheter and we get a backflow measurement, which is really measuring the left ventricular end diastolic pressure, right? It's back reading that measurement. And then there's some parameters that we actually calculate on the right heart catheterization that are not directly measured. So from some of these numbers that we get and oxygen saturation numbers that we get, as we move throughout the heart, we actually back calculate cardiac output using different metrics. Now, there's FIC measurement and thermal dilution measurement, depending on your institution, and then SIMI report or different ones differently. And then we use the pressures in the cardiac output to back calculate the resistance. So just important for us to remember what we're actually measuring and to look at those waveforms when we're actually interpreting a right heart catheterization and what we're actually deriving from those measurements. So I just want to talk about a few key parameters that we get from a right heart catheterization. The first important one, because the diagnosis of pulmonary hypertension is based on this number, is the mean pulmonary arterial pressure, or the MPAP. So this is the average pressure in the pulmonary arteries. And this is calculated similarly to how we measure just normal blood pressure based on the systolic and the diastolic pressures that we measured. Remember, right, that 2/3, 1/3. So it's the average pressure in the pulmonary arteries. What this measurement tells us is if the right side of the heart is just in general seeing high pressure for some reason. So that could be because of high resistance in the lungs, as you mentioned, Tom, or the most common reason that the right heart sees high pressures because the left heart is backing up those high pressures into the right side of the heart. So first important parameter to remember is mean pulmonary arterial pressure. And if it's high, it means the patient has pulmonary hypertension because the right side of the heart is seeing high pressures. And the number to remember here that the newer guidelines have supported is the number 20. So it's greater than or equal to 20, then it's high. And that means the right side of the heart is seeing high pressures. The second number to look for on the right heart cath is the pulmonary artery wedge pressure, or the PAWP. So what this reflects, as mentioned before, is that left ventricle end diastolic pressure. So this tells us, again, if the right side of the heart is seeing a high pressure, but it specifically tells us is that high pressure that the right side of the heart is seeing because there's high pressure in the left side of the heart that is backing up and causing the right side of the heart to see that high pressure. So the number to remember here is 15. And then the third parameter to think about is the pulmonary vascular resistance. That's the third number I generally look at when I look at the right heart cath. And this tells us how much resistance the RV has to pump against in the pulmonary circulation. And as I mentioned, this is back calculated with the cardiac output, some of the other pressures that we get in this pump system. And very important to remember the numbers and cutoff for this as well. Dave will talk a little bit about how we derive this, but we use something called Wood's units. And 2 now is the new number to remember for this. So 3 parameters, very important. First, mean pulmonary artery pressure. Second, pulmonary artery wedge pressure. And third, the pulmonary vascular resistance. And using those numbers, we can first say, 1, does this patient have pulmonary hypertension? That's solely based on that mean pulmonary artery pressure being greater than or equal to 20. 2, is it because is the right side of the heart seeing high pressures because the left side is backing up? And that we can tell based on that wedge pressure. And then 3, is there high resistance intrinsically in the pulmonary vasculature? And that we can tell based on the pulmonary vascular resistance, or PVR. And this can be really helpful as we start to think of those causes and groupings of pulmonary hypertension. But Dave, you mentioned the guidelines have changed a lot. The numbers are important. So walk us a little bit through some of the numbers and parameters and some of the more recent changes that have come.
Yeah, absolutely. Thanks, Rupali, for that overview. And for anyone who is more interested in this, performing right heart catheterizations, interpreting them, what numbers you get, and some specifics like how do you determine if you're going to use a FIC, what's the difference between indirect and direct and thermodilution, beyond the scope of this episode. But we have done a prior episode on right heart catheterization. We'll share a link in the show notes here where we talk about those things a little bit more specifically of how we're calculating the cardiac outputs, how we're using that cardiac output to generate a pulmonary vascular resistance. The one thing I'll mention is that of the relationships you mentioned is that when you have a mean pulmonary artery pressure, that minus your pulmonary artery occlusion pressure, your pulmonary capillary wedge pressure is the pressure difference in the lungs. And then that over the cardiac output, the raw cardiac output, not the cardiac index, however you calculated it, my preference is for thermodilution, but that's a whole other episode, will then give you your pulmonary vascular resistance in Wood's units. And if you want to get that into dynes, you multiply by 80, but that's how we're getting sort of these values and those core things to remember. Mean pulmonary artery pressure of 20, wedge of 15, and Wood's units of 2. So let's talk about the major update in this guidelines on the definition of pulmonary hypertension. And a few things changed in this guidelines, but I would say that this is the biggest paradigm shift. This was really in changing the Wood's units classification that we're using to identify pre-capillary pulmonary hypertension. So it's important to have a little bit of historical perspective on this. Previously, it used to be historically that mean pulmonary artery pressure was defined as greater or equal to 25 millimeters of mercury. That changed with the last World pH Symposium guidelines that lowered that definition to 20 millimeters of mercury. So why did they do that? This is all part of this effort to recognize pulmonary hypertension earlier and be able to bend the curve of a patient's ongoing course. Now, that change from 25 to 20 was extremely well evidence-based, I would argue. And there are 2 major drivers that led to that change. The first is that if you look at right heart catheterization in quote unquote normal people or patients who do not have pulmonary hypertension, do not have cardiopulmonary vascular disease, 19 millimeters per mercury is right at 2 standard deviations above the mean. And so it's pretty reasonable to say that 95% of people, or the vast majority of normal people, will have a mean pulmonary artery pressure less than 19 millimeters of mercury. There was a big gap there between 19 and 25. And so it was reasonable to lower the diagnosis of pulmonary hypertension to 20 to right above that upper limit of normal. The second is that studies of patients who had connective tissue disease, specifically scleroderma, which are well known to have pulmonary hypertension and have poor outcomes from it, showed that there was a difference in mortality starting at that mean pulmonary artery pressure of 20 to 25. Patients who had mean pulmonary artery pressure less than 20 did better than patients that were 20 to 25, who did better than patients who were above. So our prognostic influence was already happening there. So they lowered it to 20. Now, when they lowered that diagnosis to 20 millimeters of mercury, they did not change the pulmonary vascular resistance cutoff, which was 3 Woods units historically, which is interesting because those numbers will end up being related, right? So pulmonary vascular resistance is calculated for mean pulmonary artery pressure minus pulmonary capillary wedge pressure over cardiac output. So if you lower one of them, how do you not lower the other one? But it made sense as they were recommending it based on studies that we've had of pulmonary vascular resistance. The curve is a little bit different. And then also based on all our trials of treatments in the past. However, there's a new updated guidelines essentially aimed to reinform or correct that. And so they said, look, we're using a lower number to diagnose pulmonary hypertension. We should be using a lower number to diagnose precapillary disease and recognize precapillary disease earlier in a patient's diagnosis. So that was the main driver for them making this change. So I've referenced this precapillary, postcapillary things a few times, and this is what we should really take away from our right heart catheterization from this section, is that once we have these values, and assuming the right heart catheterization was well done and everything is accurate, we can classify the patient into no pulmonary hypertension, precapillary pulmonary hypertension, isolated postcapillary pulmonary hypertension, or mixed pre and postcapillary pulmonary hypertension. So what are those categories? No pulmonary hypertension, the patient's mean pulmonary artery pressure is less than 20, right? They do not have pulmonary hypertension. Even if the patient has a slightly elevated pulmonary vascular resistance, they do not meet criteria for pulmonary hypertension. Now, I, as a specialist provider, might pay more attention to that person, but they do not have PH. Mean pulmonary artery pressure above 20, they have pulmonary hypertension. If their pulmonary capillary wedge pressure is greater than 15 and their pulmonary vascular resistance is less than 2 Woods units, that is isolated postcapillary pulmonary hypertension. This is right heart overload from left heart disease. Most common reason worldwide why you have pulmonary hypertension. And so we do not have to think about any of our pulmonary vasodilator therapies. These patients need optimization of their left heart function and filling pressures. If they have a mean pulmonary artery pressure above 20, a pulmonary capillary wedge pressure less than 15, and a pulmonary vascular resistance above 2 Woods units, they have precapillary pulmonary hypertension. They have pulmonary hypertension due to intrinsic remodeling or process in the pulmonary vasculature. We need to think of these patients as having a primary pulmonary vascular disease, and that will dictate how we monitor and end up treating them. Now, that could be seen in patients with group 1, group 3, group 4, even group 5 disease. It doesn't tell you the mechanism underlying of why that vascular resistance is up. So that could be because they have hypoxemia that's sort of just leading to hypoxic vasoconstriction or pulmonary arterial hypertension, but we know they have a precapillary process. And then there are those people who have a little bit of everything, right? So their mean pulmonary artery pressure is greater than 20, their wedge is greater than 15, but their pulmonary vascular resistance is also up above 2. And so these patients have combined pre and post capillary disease, and we're going to have to think about optimizing multiple factors at once.
Thanks, Dave. That's extremely helpful. I was wondering if you could just take another minute, maybe, because sometimes in the clinic, we've looked at those 3 parameters that we've talked about, the mean pulmonary artery pressure, the wedge pressure, and then the pulmonary vascular resistance. But oftentimes patients can, especially in this patient, my situation, say that they had developed ILD, can come in with mixed disease categories and you could have developed group 2 disease as well over time. And sometimes I ask myself in clinic, how should I think about how much of their disease is related to their group 2 disease or the heart overload from the left side of the heart versus how much is this precapillary component? So when they have mixed, but I know there are some ways that we can think about. Can you just touch on that for a minute?
Yeah, this is where things get a little bit tricky, right? There are some metrics that people have used. We can talk some about the transpulmonary gradient, right? This is the mean pulmonary pressure over the wedge, which is above 12 would be abnormal. We can talk about the diastolic pulmonary gradient, which is a diastolic pulmonary pressure minus the wedge, and 7 would be the number to remember there. Sometimes we start looking at pulmonary artery compliance. We're actually looking at how much stiffness is there in the pulmonary artery by each stroke volume. And these can give us some hints. There are also other metrics in general that we can use outside of the cath, right? So if we have a patient who has group 3 disease specifically, like they have some ILD, we can start looking a little bit at the ratio of their FVC to their DLCO, right? So if their FVC is only mildly reduced, but the DLCO is severely reduced, maybe a little bit of less of this is the parenchymal lung disease and more of it's the pulmonary vascular disease. I will say overall, none of these metrics is perfect. It's somewhat a gestalt, but it's a little bit like when you see it, you know it for part of the times, right? And so especially with the pre and post combined disease, like sometimes I have a patient whose pulmonary capillary wedge is 29 and their pulmonary vascular resistance is 2.8. And I'm like, yeah, sure, you have combined pre and post, but this is left heart disease, right? Sometimes I have a patient whose wedge is 16 and their PVR is 14. And I'm like, I don't really even care that your wedge is elevated. This is precapillary disease. It can be difficult to distinguish. We can use some of these metrics. For that circumstance that you mentioned, there's some data on trying someone on more oxygen and seeing how much their pulmonary vascular resistance goes down to distinguish group 3 versus group 1. That's a very imperfect test. So this is where we get into some of the art of this practice.
Furf, that was awesome. Thanks so much for walking us through that. Once you start talking about numbers and how to multiply and get dynes, you kind of lose me sometimes, but I love the passion that you have for these right heart cath numbers. And again, in all seriousness, though, a great job of reviewing it for us. I do want to go back, though, to Tom's earlier point when he talked about potentially having a patient undergo vasoreactivity test, right? So now let's assume our patient's in the cath lab, and you have to decide whether or not to consider vasoreactivity testing. I think an important point that we hope that you get today from listening is that this test is only indicated for patients with idiopathic, heritable, or drug-induced pulmonary arterial hypertension, or PAH. It's performed during the right heart catheterization itself using either inhaled nitric oxide or another short-acting vasodilator. I know that it can be institution-specific. But what are we going to be looking for to see if someone has a positive test? And what does this actually mean if they do? So why we want to do this in this specific cohort of patients is to see if they may benefit from long-term treatment with high-dose calcium channel blockers. And although this is rare, this can happen, and for these patients, it can be very beneficial. But a positive vasoreactivity test is defined as a decrease in mean pulmonary arterial pressure of greater than or equal to 10 millimeters of mercury to an absolute value of greater than or less than 40 millimeters of mercury, with no reduction in cardiac output. So again, greater than or equal to 10 through the spectrum of less than or equal to 40 and no reduction in cardiac output. Importantly, vasoreactivity testing, as I mentioned, is useful in this subset of patients for prognostication because patients tend to have a better long-term outlook and for identifying those who may respond to calcium channel blockers, as I mentioned. However, it's important to note that this should not be used to predict response to other classes of pulmonary vasodilators, despite common misconceptions. Furf, I'm sure we can have a whole other episode on vasoreactivity testing, but just wanted to bring it in at this point as we're thinking about things before we transition to other topics.
Okay, thanks so much, Christina, for covering vasoreactivity testing. Such an important part of thinking about both during the diagnosis of pulmonary hypertension and then for treatment as well, and being mindful of our treatment parameters with those calcium channel blockers, as you mentioned. But now I'd like to shift a little bit to cover screening in high-risk populations, specifically thinking about which patient population should be screened for pulmonary hypertension. One of these patient populations is actually the patient population that my patient comes from, which is the systemic sclerosis population. The current guidelines recommend annual screening if the patient meets these parameters. So first, if they've had disease duration greater than or equal to 3 years, which my patient had, if FVC on pulmonary function testing was greater than or equal to 40%, which my patient also met, and if the DLCO was less than 60% as well. So this fit my patient's profile. And so the screening tool that the guidelines refer us to is something called the DETECT algorithm. It's a 2-step process that is able to catch early PAH, so group 1 PAH in these patients, and involves gathering some other information, including the FVC to DLCO ratio that David previously mentioned, the NT-proBNP that we've talked about, and some other screening tests, including anti-centromere antibodies, looking for right axis deviation on EKG, and then looking for other physical exam signs like telangiectasias. Then once we calculate the score, if it is high, that's the first step of the algorithm. Then we can move to step 2, which incorporates echo findings into this algorithm. Specifically, we use some of those things that we mentioned, including the TR velocity and the right atrial size. If those are both abnormal as well, then the recommendation is to refer the patient for right heart catheterization, because as we mentioned, that is the definitive way to look for pulmonary hypertension. This 2-step DETECT algorithm has a very high sensitivity, so it is ideal for screening, especially before symptoms develop. If I had been able to follow this patient earlier, before my pretest probability was so high and she had met these parameters, it would be important to think about using this algorithm firsthand in clinic, potentially even sending her for right catheterization before symptoms developed in order to catch it early. Tom, what are some other high-risk populations we should be screening for pulmonary hypertension in?
Yep, absolutely. As you were alluding to, connective tissue diseases, particularly systemic sclerosis, those are patients that we really need to think about their risk of developing PAH. But there's a lot of other conditions that our guidelines call out that are particularly high-risk groups. These include particularly those with known genetic mutations that are associated with the development of PAH. The classic one that we learn about here is BMPR2. That is probably the most high yield one to screen patients for. But then there's also other things that patients will have. People with cirrhosis who develop who develop portal hypertension. Those patients are at risk for developing pulmonary hypertension. Patients with HIV. These are all pretty high risk groups. In these high risk groups, the guidelines do recommend annual screening. This can occur through echocardiogram, NT-proBNP, pulmonary function testing. And just for a few pearls to take away, patients with heritable PAH or a known BMPR2 mutation, annual echo screening is recommended. This should occur even if patients are asymptomatic. And this also holds true for patients with portal hypertension. This is particularly important if you're thinking about someone with portal hypertension due to their cirrhosis, and you're going to think about sending them for transplant evaluation, or maybe they need a TIPS for refractory ascites. This often is an important part of their evaluation process, and you should screen them usually with an echocardiogram.
Yeah, great point. In the portal pulmonary hypertension is a super interesting topic. We've done an episode about that, but I think maybe as part of this series, we'll do a more specific one, because liver transplant is just such a big field now, right? And so well tolerated. And so they've been pushing the boundaries of who's an acceptable candidate. And so we've been doing more and more of these patients with portal pulmonary hypertension and trying to get them to goal to get their liver transplant. Really evolving and interesting topic.
Great. Thanks so much for Tom, for walking us through that. Want to end today with a few takeaways. We've had such a great discussion so far, and only our first of a series in our pulmonary hypertension guidelines that I think are going to be really high yield and hopefully very instrumental in giving you a framework to think about pulmonary hypertension in your patients. But the ESC ERS guidelines lay out a 3-step diagnostic pathway for us. First, we need to have suspicion of pulmonary hypertension based on symptoms. Second, detection with echo, PFTs, and labs. And third, confirmation with a right heart cath. I think that we demonstrated this nicely with the case that Rupali grounded us in to start with and that we walked throughout our time together. So thinking about pulmonary hypertension early in patients with unexplained dyspnea, especially when symptoms seem out of proportion to PFTs or imaging, use the WHO classification to guide your differential and workup. Remember that echo helps you estimate probability, but right heart cath is essential for diagnosis and classification. And don't forget the high risk populations where we should think about screening early.
All right, that's a wrap for today. This was awesome. Thank you, Tom and Rupali, for guiding us through this. I know we're just getting started, though. In our next episode, we'll move beyond this diagnosis and we'll talk about risk stratification. We are never using just one of these parameters. We use these combined risk scores. So we'll cover that, talk about functional class, biomarkers, exercise testing, RV function and hemodynamics, and go through some of these common risk scores. And then we'll start introducing our treatment categories and go into treatment by these specific diagnoses or groups. So really looking forward to it. Tom, Rupali, looking forward to having you guys back very shortly.
Always a pleasure, Dave. See you guys next time.
See everyone soon.
Yeah, and thank you all for listening. This episode was written by Rupali and Tom, edited by myself and Christina, all recorded together. And the music is original music by Eric Rogers. And we'll see you next time.